Welcome back, everyone. Today we are diving into the very foundation of the human frame. We aren't just talking about bones as a generic concept, we are looking at the architectural genius behind them. I'm joined by Dr. Sarah, who is going to keep us focused on those high-yield details that show up on exam day.
Thanks, Dr. Khan. It's a pleasure. When students approach the skeletal system, they often get bogged down in naming every bump and groove. But the real key to mastering the boards is understanding the structural differences between the two main types of bone tissue, compact and cancellous bone.
Exactly. I like to think of it as the shell and the scaffolding. Imagine a skyscraper. On the outside, you have these massive, solid concrete walls that protect everything inside. That's your compact bone. But on the inside, you have this intricate, cross-braced network of steel beams that absorb the weight and handle the wind. That's your cancellous bone.
That's a great clinical image. To be precise for the exams, compact bone is also called cortical bone. It appears as a solid mass to the naked eye. In contrast, cancellous bone, also known as spongy or trabecular bone, consists of a branching network of trabeculae. These are like little beams or struts that create an open, porous structure.
And why does this matter clinically? Well, look at where these types are located. If you take a long bone, like the humerus or the femur, the shaft, the diaphysis, is mostly a thick tube of compact bone. It has to be. It's the lever that your muscles pull on. If your femur was all spongy, it would buckle the moment you tried to sprint.
Right, but the ends of those long bones, the epiphyses, are a different story. They are filled with cancellous bone, surrounded by only a thin shell of compact bone. Board exams love to ask about the metaphysis, which is that transition zone in a growing bone where the diaphysis meets the epiphyseal plate. It's a hot spot for metabolic activity and growth.
I love the architecture of the epiphysis. If you look at an X-ray of the head of the femur, those trabeculae aren't just randomly scattered like bubbles in a sponge. They are aligned along the lines of stress. They are literally biological struts designed to transfer the weight of your torso down into your legs. If you change how a person walks, those trabeculae will actually remodel themselves over time to meet the new stress. Bone is alive.
That leads us to a very high yield point regarding flat bones, like those in the skull. On the boards, they might use the term diploe. Do you remember that one, Dr. Khan?
Oh, the bone sandwich. That's how I describe it to my residents. You've got an outer table of compact bone, an inner table of compact bone, and a delicious filling of cancellous bone in the middle called the diploe. It's the perfect design for protection. The outer layer takes the hit, and the spongy middle absorbs the energy before it reaches the brain.
Spot on. Now let's talk about what's inside the spaces of that cancellous bone. At birth, the marrow in all bones is red and hemopoietic, meaning it's producing blood cells. But as we age, there's a shift. By age 7, yellow marrow, which is basically fat, starts appearing in the distal limb bones and moves proximally.
Why does this matter clinically? Think about a patient who needs a bone marrow biopsy. You aren't going to go to their forearm in an adult. You're going to the axial skeleton, the sternum or the iliac crust. Why? Because that's where the red marrow persists in adults. It stays in the skull, vertebrae, ribs, and the heads of the femur and humerus.
Exactly. And for the STEP exams, you must know that cancellous bone has a much higher surface area to volume ratio than compact bone. This makes it more metabolically active. When a patient has a condition like osteoporosis, which bone type do you think is affected first?
It's the cancellous bone every time. That high turnover rate makes it the canary in the coal mine for bone density loss. This is why we see compression fractures in the vertebrae or hip fractures at the femoral neck. The scaffolding on the inside starts to crumble before the outer shell even looks thin.
Which is why being the doctor of choice for an aging population means understanding this transition early. If you can explain to a patient why their spine is at risk, even if their bones look fine on a standard X-ray, you're providing superior care.
Let's talk about the periosteum for a second, Sarah. It's that fibrous sleeve covering the compact bone. I always tell my students, the bone doesn't feel pain, the periosteum does. It has a massive nerve supply. When you see a patient with a fracture, that severe crushing pain is the periosteum being torn and the hematoma building up underneath it.
That's a great clinical pearl. And from a board perspective, remember that the periosteum is where the osteogenic cells live. It's essential for healing. Without a healthy periosteum and its blood supply, you're looking at non-union of a fracture, which is a surgical nightmare.
So to wrap this up, we have compact bone for strength and protection, and cancellous bone for metabolic activity, hemopoiesis, and shock absorption. One is the armor, the other is the engine.
And the key takeaway for your exams, compact bone forms the diaphysis and the outer tables of flat bones, while cancellous bone contains the trabeculae and red marrow in the axial skeleton. Osteoporosis hits the cancellous bone first due to its high turnover.
Great summary. Next time, we'll talk about how these bones actually join together. Until then, keep thinking about the why behind the anatomy.